Good evening, and thank you for joining us for the National Health Service Corps' 2012 webinar series. Tonight's webinar is Community Engagement in Smoking Cessation, What to Do with a Patient Who Smokes. You will hear from Dr. Stephen Schroeder, a distinguished professor of health and healthcare at the University of California, San Francisco, where he is also director of the Smoking Cessation Leadership Center. Joining Dr. Schroeder tonight is Reason Reyes, the Director of Technical Assistance with the Smoking Cessation Leadership Center. Smoking-related illnesses are among the leading causes of death in this country. This webinar's goals are to make the case for clinical intervention, share information about successful partnership programs, offer tips on working with patients, and provide resources for providers. NHSC is pleased to offer continuing education units and continuing medical education credits of 1.5 hours for all disciplines participating in this webinar. To receive these hours, you must attend the full 1.5-hour session. Throughout the webinar, you will be required to respond to online poll questions to verify attendance for the accreditation process. Once you respond to all the questions, your attendance will be noted. At the conclusion of the presentation, the operator will provide instructions on how to submit a question through the operator via the conference bridge line. There will also be an evaluation after the Q&A session. We would appreciate it if you took a minute to fill it out so we can continue to improve our future sessions. Thank you again for joining the 2012 NHSC webinar series, and we hope you find this webinar useful to your daily efforts to provide service in your community. Now please welcome Dr. Stephen Schroeder and Reason Reyes.
Thanks very much. It's very good to be with you, even though it's in an electronic form. And our hope is that at the end of this session, you'll feel more confident and more able to help smokers quit, because it's one of the most important things you can do. So here's what I'm going to talk about in my part of the presentation: facts about smoking and health, the epidemiology, the policies that can help to lower the use of any tobacco products, and then getting into real clinical issues, how to help people stop smoking, the issues of nicotine, smoking cessation aids, and telephone quit lines. So let's start with facts. This is a pretty stark slide. Almost 450,000 deaths in the United States every year, almost 5 million deaths worldwide, estimated there may be 10 million deaths by 2030. 50,000 of those 450,000 deaths are due to people who are not themselves smokers, but get injured by exposure to secondhand smoke. And 20 times the 443 million, that's 8.6 million, are disabled from tobacco use, generally smoking. They have emphysema, they have lung cancer, they have heart disease. There are about 45 million smokers in the United States today. About 4/5 of them are daily smokers, and they average about 15 cigarettes per day. And here's how smokers who die. Cardiovascular disease, lung cancer, respiratory diseases, and others. So smoking does you in a lot of different ways. This is a slide that I update periodically, and the more recent updates are in yellow. I won't read this whole slide, but I hope you're impressed with all the different ways that smoking is injurious to your health. And you notice in the yellow, in the last couple of years, there have been papers to show that both the incidence of prostate cancer and the survival when you get it are impaired by smoking. That is, smokers are more liable to get prostate cancer, and those smokers who get prostate cancer don't do as well as people who don't smoke and get prostate cancer. On the right-hand side here, you can see the type 2 diabetes, more commonly occurs among smokers, and also the complications of diabetes are greater because of the arteriosclerotic complications from smoking. And then at the bottom there, smokers have a higher odds ratio of getting Alzheimer's, rheumatoid arthritis, and sleeping less well. Now, many clinicians will say, when I'm confronted with a 60-year-old smoker, is it worth getting him or her to try to stop smoking? And the answer is yes, and I'm going to show why on these next two slides. So within 2 weeks to 3 months, circulation gets better, lung function gets better. Within 1 to 9 months, the lung cilia get better. Now, you're liable to hear from smokers that when they stop smoking, they're coughing more. And that's because of two things. One is the cilia come back, and secondly, all those goblet cells that were creating all the mucus will phase out, but as they phase out, they'll be putting that mucus out, and now the cilia can bring them up. So tell your patients who stop smoking that it's okay that they're coughing more in the short run, but that's going to stop. Within a year, your excess risk of coronary heart disease is down to half of that of your twin who kept smoking. Within 5 years, your risk of a stroke is reduced to that of people who never smoked, which is great. Within 10 years, your lung cancer rate drops to half of that of a continuing smoker, and your risk of other cancers will go down. And after 15 years, your risk of coronary heart disease is similar to that of the level of a person who hasn't smoked. So you can see all the benefits, and these are true at every age. Now this next slide is an interesting slide. It looks a little complicated, but it is 6 different curves. The bottom curve, which is almost flat, shows the cumulative risk of dying from lung cancer in men. And you can see it's really great. It's really very, very trivial. The top line, which is solid, shows a cumulative risk of dying from lung cancer if you keep smoking all of your life. You go down to the next lower one from that top one. It's what happens when you stop at age 60. The next one is age 50. The next one is age 40. And the next one is age 30. So your risk of lung cancer decreases even if you stop at age 60 as compared if you kept smoking. Now, smoking is especially concentrated in people with mental illness and or substance abuse issues. Of those 443,000 deaths I showed you on the first slide, 200,000 of them occur among people with either chronic mental illness and or substance abuse problems, that is alcohol, cocaine, heroin. This population consumes almost half of all the cigarettes sold in our country. And this is a function of the fact that people with these conditions are more likely to smoke, and when they smoke more. They also are more likely to smoke it down to the butt. So if you go outside an AA meeting, you'll see a Marlboro filter, but you won't see hardly any tobacco on the discarded cigarettes. People with chronic mental illness die on average 25 years earlier than others. And they don't die mainly from suicide or homicide or even alcoholic cirrhosis. They die mainly from complications of smoking. The other two things, one on the slide and one not, that is a consequence of smoking in this group, are that it's a social isolation. If one of the goals of people with chronic mental illness is to enter the mainstream, to be part of the wellness community, it's hard to go out and look for a job if your fingers are yellow or if your clothes smell of cigarette smoke. And the other thing is cigarettes are very costly, and many of these people don't have much money. So a lot of the people you're seeing panhandling may not be panhandling for alcohol or drugs. They may be panhandling actually for cigarettes. Now, just as I had the list of causal associations with smoking, these are associations with secondhand smoke. And you can see that they're very consequential. For the pregnant mother, the children are more likely to be born early, to have low birth weight, to have sudden infant death syndrome, to have a depression in their childhood. And you can see the respiratory complications, the carcinogenic complications, and the cardiovascular complications. So just as in primary smoking, secondhand smoking causes a lot of problems. Now, what is it about the tobacco smoke? Well, there are about 7,000 compounds, including 69 proven human carcinogens. These include gases like CO and cyanide and all the particles. It's important to note that nicotine is not the agent that causes the ill effects of tobacco use. Nicotine is the stuff that gets you hooked. It's an addictive drug. I gave grand rounds at a UCSF hospital last week, and a very smart senior professor of medicine came up to me afterwards and said, Steve, this is the first time I've understood that it's not the nicotine that causes you to have cancer. And I was surprised because she is so able, but I figured if she thinks it, maybe lots of other people do. So now let's talk about the epidemiology. You can see here that starting in the mid-1950s, there was a big gender gap, and men smoked more. There were more male smokers than non-smokers. About 55% of adult men smoked, about 45% men. The two trends that have happened since then are, one, the male smoking rates have gone down, and secondly, the women started smoking more, and then their rates came down. And part of why they started smoking more was a brilliant ad campaign by the folks who make Virginia Slims, which was called You've Come a Long Way, Baby. And indeed that happened. And now women who smoke like men die like men who smoke. You'll notice that the smoking prevalence in 2010 was 19.3%. That was an all-time low. It's likely that the 2011 smoking prevalence, which the CDC is going to come out with, I think this very month, is going to be even lower. Now, people used to think that as we got smokers to quit, the ones who quit were the light smokers. And so there would be what was called a hardening of the smoking. And that is that the people who kept smoking would be the heavier and heavier smokers, so it would be hard to get them to quit. Well, we analyzed data from the CDC, and you can see on the red line that as the blue line smoking came down, the smokers who kept smoking were smoking in about a pack per day from 1965 till about 1995, and then they began going down too. So the smokers who smoke today are smoking about 13 daily cigarettes as opposed to, say, 20 in 1995 or 1965. Now, the reasons they smoke less may be because smoking is more costly and there are more barriers to smoking in a public place, but it should give you encouragement that those who have continued to smoke are not necessarily the hardcore cases. This is a sad map that shows that cases of lung cancer are concentrated in the regions of the country, mainly the southeast, where smoking rates are higher. It's a very grim map. The lowest smoking state in the country is now Utah, about 9%. The rate in California is about 12%. If you discount for the fact that Mormons don't smoke, and about half of Utah's Mormons, then the rate in Utah is up to 18%. What about by racial characteristics? Native Americans have the highest rate, and there are complicated reasons for that. But whites of the larger population, of the larger groups, have the highest rates, followed with a small proportion less by blacks. And people of a Hispanic or Asian ethnic group have the lowest rates. Now, it's interesting because Asians come from countries where at least the men have rates of smoking 50 or 60%. And why are the rates so low here? Well, there are two theories. One is that people who don't smoke kind of selectively immigrate to the United States. That turns out that's not true. It's that when they get here, they realize that smoking is not nearly as socially acceptable as it was in their home countries, and so they stop smoking. As you can see, I'm no longer a young man, and in my parents' era, smoking was a glamorous thing. Both my parents smoked. They were educated. Many of their friends smoked. But over time, smoking has become deglamorized and relegated to people of lower social status. So as you can see here, smoking is, the rates of smoking go up as your educational level goes down. Now you might ask why the rates are so high for people who get their high school degree as a GED. The answer for that probably is that so many prisoners get a GED, and so many people are in prison because of drug use or alcohol, and so many of those people smoke. So, what about the policies? What can we do as a social group, as a country? What policies can we do to reduce smoking rates? Well, one thing we can do is make smoking more costly. And you can do that with federal taxes. You can see that the taxes stayed pretty low until 2009 when we financed the extension of the S-CHIP program to expand health insurance coverage for children by taxing a cigarette, by increasing the taxes by 62 cents per pack. There are also state taxes, which vary greatly, very high in the Northeast, much lower in the Southeast. And then there are city taxes, like in New York City. So the number of smokers is a function of the new smokers plus the continuing smokers minus smokers who quit minus smokers who die. And what we want to do in this session is to encourage the number of quitters. And quitters, there's sort of two functions to the quitting. One is the attempt to quit. And the average quitter takes 8 to 10 times, they have 8 to 10 attempts at quitting before they actually quit. And what impels someone to try to quit? Well, it's raising the price of a pack of cigarettes with taxes, clean indoor air laws so it's harder to smoke, counter-marketing such as the Legacy's Truth campaign, the advice of a clinician, doctor, nurse, pharmacist, others, and then what increases the likelihood that a quit attempt will work? Well, one is, again, the advice of a clinician, drugs, and counseling, and we'll come back to those. I'm going to show you something which I hope won't be the last time you'll see them, but these are policies that in other countries have helped to scare smokers from quitting, from smoking, to help them quit, and also to discourage younger smokers from starting. These are FDA graphic warnings that they were entitled to by recent legislation, but that were ruled to be not legal in a district court, and they're being brought up to the next higher court. So I'm going to show them to you, and I hope you'll see them on a pack of cigarettes, but I don't know that's going to happen. Here is someone smoking through a trach. Here is a child being harmed by secondhand smoke. Here are a pair of healthy lungs and a pair of diseased lungs from smoking. Here is an oral cancer. Here is someone who's had an MI. Here is a fetus who's exposed to smoke because of the baby's mother. Here is a cadaver from someone who died of smoking. Here is a woman who's got lung cancer, and she was not a smoker, but she got it from her spouse. And here's a dude that says, I quit. So I hope you'll see those, and if not, you've seen them here. So moving on to issues of a clinical nature. A recent study by the AAMC and the Legacy Foundation showed that of over 3,000 doctors, only 1% were current smokers. You recall that people with a graduate degree, about 5% were smokers. By the way, for the nurses listening, in my era, smokers, those who were nurses, had higher smokers than the population, and now the nursing smoking rate has come down to about 12%. It's still too high, but it's lower than it was. Pharmacists and dentists and dental hygienists have rates of about 5%. What the Legacy survey showed was that doctors were really good at asking about smoking and counseling the smokers to quit, and then they didn't recommend nicotine replacement therapy or other drugs. They were terrible at doing follow-up, and they essentially didn't refer anybody to a quit line. So the good news here is there's a lot of opportunity to do a better job. Our center has found these 5 reasons for why smokers don't do a good job, for why doctors don't do a good job in helping smokers quit. And it's true of nurses and pharmacists and others also. One real reason is they're too busy, and it takes a while. A second rate is that many don't have the expertise, or they don't get a financial incentive. That's kind of a hollow excuse as far as I'm concerned. We don't get a financial incentive to take somebody's blood pressure or to see how much they weigh. That they don't know how to make somebody quit. The reality, and this is a sobering issue, that most smokers can't or won't quit. The unassisted quit rate, the cold turkey quit rate, is about 3%. So that, and the best quit rates are 10 to maybe 15 or 20%. That means that most of your smokers, when you try to help them quit, won't quit. But as I'll show you later, even if you increase those low rates to a little bit higher, you'll probably be doing more for your population than anything else that you can do. Now, if only 1% of doctors smoke, they're likely to stigmatize smokers and to think to themselves, you know, that wasn't a very smart choice. And the answer is, well, most people who choose to smoke start at about 13 or 14. And as a father who's had kids that age, their judgment isn't very good at 13 or 14. So have some sympathy. Respect for privacy. That's true. Smoking is a private act, but your job as a healer to help them to stop smoking. Some people worry that you're going to lose patients, clients, if you talk about smoking. But in fact, even smokers with no intent of quitting say that if a doctor doesn't ask them about their smoking, they're not sure they're going to care about breast cancer or heart disease. So ask. And then finally, for those rare clinicians who do smoke and say, I'm a hypocrite if I try to get people to stop smoking, you above all ought to know that you should help people to stop. So what we say is that there are 4 responses to a patient who smokes. The first one, I don't have time, no, it's unacceptable. The other 3 are, and they are in ascending difficulty, refer someone to a telephone quit line or a web program. We call that take 30 seconds and save a life. Or set up systems in your office or hospital, and hopefully some of the clinics where you work will do that. Or, as you've done by signing up in this session, become an expert on your own. Now, tobacco dependence is a 2-part problem. It involves, I'm going to go back one. It involves having an addiction to the nicotine, which, as you'll see, changes your brain, and there are medications to help you there. And then it's a behavior. So people get hooked into smoking. Even those who don't smoke enough to have an addiction to the nicotine have certain visual cues. And so what we want to do is change both the physiologic and the behavioral reasons why smokers smoke. And advanced part. So these are the 5 A's, and every clinic ought to have this pamphlet that's in the upper right-hand corner, and you can get it by contacting the CDC, and it's by Mike Fiore and his colleagues, and it's called, as you see at the bottom, Treating Tobacco Use and Dependence, 2008 Update. So you all ought to have it because it's the single source of all the evidence of all the publications that have been done. And these famous 5 A's are for you to ask about tobacco use, advise users to quit, assess their readiness to quit, assist with the attempt, and arrange follow-up care. And these are very, very critical. Now, there are measurements of smoking intensity that you can do in your clinics. One is the Fagerstrom test. I'm going to show you that. And the other are biochemical markers for smoking. Nicotine is broken down into cotinine, and you can test the levels in the blood, the urine, or the saliva. Or you can have someone breathe into a breathalyzer and measure the parts per million of carbon monoxide. And those in non-smokers ought to be 0, 1, or 2. And in smokers, they're anywhere from 10 to a couple of hundred. Many smokers like to see how they've changed as they've cut back or stopped smoking. So again, this is one of the nice things you can have in your office. This is the Fagerstrom test. And you can see here that it gives points. The maximum is 10. Usually if you have 5 or 6, that means you're a pretty confirmed smoker. And you notice that it's really weighted on the first question. You get 3 points if you smoke your first cigarette within 5 minutes of getting up. You get a point if the one you'd hate to give up most is your first morning cigarette. And the fifth question is, do you smoke more frequently during the first hours? So that first morning cigarette, there's one question you can ask. It's, when do you have your first cigarette? Now, let's turn to the pharmacology of nicotine. The tobacco industry tries to alkalize the tobacco because it's pH dependent. And so in the sweet spot of 7.3 to 7.5, nicotine is more readily absorbed. A cigarette is a wonderful distribution vehicle to get nicotine to the brain. You take your puff of cigarettes, of a cigarette, and it gets to the nicotine gets to your brain within 11 seconds. So people have said that a cigarette is a nicotine delivery device, and you can see how quickly it gets into the arterial blood. The pharmacodynamics of the nicotine are that it goes into the central nervous system. It creates pleasure. It makes you more kind of aroused. You can concentrate more. If you're anxious, it may make you feel better. Suppresses your appetite, which is why when smokers quit, they sometimes or often gain weight. And it does things to your cardiovascular system, as you can see. Now this is a schema, a cartoon of the brain. You can see that nicotine enters the brain through the arteries, and it stimulates nicotine receptors in these two central areas in the central brain. The nicotine receptors release dopamine. The dopamine then goes to the prefrontal cortex, and it goes, ah. So dopamine is the thing that makes you feel good after alcohol, after cocaine, after heroin, after smoking, and in my instance, after hearing Beethoven. So it's the pleasure mediator, and this is why smoking feels so good. Now, many of you have been in the presence of people who are trying to stop smoking. And on this slide, it shows the withdrawal effects when you stop using nicotine. And you can see that these can be pretty bad. And some spouses and some coworkers have sometimes said, for goodness sakes, Kathy or Kevin or Joe, go back to smoking because we can't tolerate you that you've stopped smoking. Fortunately, most of the symptoms manifest within the first 1 to 2 days. They peak within the first week, and then they kind of subside. And the principle of many of the medications to help smokers stop is that it blunts or stops withdrawal from the nicotine. Now, this is what smokers do. They keep in that sweet spot. You can see when they wake up, the blood level of the nicotine is essentially 0, and they smoke to keep within that band. As I mentioned, the real culprit isn't the nicotine, it's those 7,000 chemicals, the smoke, the tar, the additives. So nicotine replacement therapy, which is one of the pharmacologic agents to help smokers quit, is helpful, not harmful. It is a clean form of nicotine. So you don't need to worry. You can reassure your patients if you want to prescribe this or tell them to get it over the counter that it is okay to use. Social support is very critical. Key ingredients for quitting are social support as a part of the treatment, both inside and outside. And it's very difficult for a patient to quit smoking if their spouse smokes or if their best friend smokes or if their partner smokes. So as the 2008 guide shows, pharmacotherapy is an important part of your quit attempts. And I'm going to show you how. There are 7 different ways that you can give drugs to help smokers quit. 5 are versions of nicotine replacement therapy, NRT. The gum, the patch, and the lozenge you can all get over the counter, although many state Medicaid programs will give them free of charge to people on a state Medicaid program. The nasal spray and the inhaler, which are much less commonly used, you need a prescription for. Then there's the partial nicotine receptor agonist, varenicline, which is known as Chantix in its drug brand, which blocks the nicotine receptor, making it harder for you to get the buzz when you smoke, but making it also making the withdrawal less poignant. And then there's bupropion, which is an antidepressive. It's known in the smoking cessation drug by its brand name of Zyban. So counseling plus medicines are better than either by themselves. I'm going to go quickly through the 5 versions. The nicotine gum gives you, it satisfies oral cravings. It might postpone the weight gain, although you often will get it. Patients can chew as they need to when they get the urge, get a variety of flavors. The problems are that people with dental work, it makes them worse. You need to use it right. I'm going to show you that in a minute. And sometimes gum chewing isn't socially acceptable. Most people many who use the nicotine gum use it wrong. You don't chew it like a chiclet. You park it in your buccal area, and you chew it once or twice. You feel the peppery taste, and then you park it. You chew it slowly, and you chew it when you feel the urge to have a cigarette. And you're not supposed to eat or drink before or after using it, because then it blunts its power. The nicotine patch is probably the single most important version of the nicotine because it gives you a daily drip, drip, drip of the nicotine, and it prevents you from getting from being as edgy by not getting nicotine from your smoking. So it gives you constant levels, comes in 3 strengths, and the more you smoke, probably if you smoke 15 cigarettes or more daily, you ought to use the 21 milligram. You can slap it on in the morning on an arm or a belly, and no one knows that you're doing it, so there's not any stigma, and the compliance is good. The disadvantage is you cannot titrate the dose, so often people pair the patch with the gum. You can get an allergy, but you can treat that with over-the-counter hydrocortisone. But if you got eczema, you probably shouldn't use it. The lozenge is really similar to the gum, the oral cravings. It tends to be not as much used as the gum is, probably because the GI side effects are greater. Nicotine nasal spray can give you irritation in your nose or your throat, can make you sneeze, but the patients can titrate it, and some like it, as they do the inhaler. The inhaler is not like a bronchodilator. It doesn't go down to your lungs. It goes to the back of the pharynx, and it gives you nicotine, which is absorbs there. So varenicline is the newest drug. It was a designer drug specifically designed to sit on the nicotine receptor. Came out about 5 years ago, and the early trials show that it was better results than bupropion, and I mentioned how it works. The common side effect is nausea. Most people get over that, and that's the reason that you start with a lower dose and work up to the 2 mg daily. The advantages and disadvantages are shown on this slide. It's easy to take. It's just twice a day. It's got a new mechanism, and it seems to work, as you'll see in some of the head-to-head trials. The disadvantages are the nausea, although that gets better. In chronic renal failure, it's broken down in the kidney, so you've got to give a lower dose. We're just beginning to understand some of the complications, and there are 2 that I want to mention. One is a rare but important psychiatric syndrome that about 100 reported cases of suicidal attempts, some that unfortunately led to suicide, have occurred. There have been close to 10 million prescriptions, so it's hard to know how frequent it is and whether it's causal or whether it's because people who take the drug may also be chronically depressed or because some people are depressed after stopping smoking. The FDA has asked the manufacturer to study this and see how common it is, but frankly, because it's so rare, I don't think Pfizer is going to be able to get a definitive answer there. The other thing is that 2 studies have looked at whether cardiac events may be more common, looking at pools of all the studies in the early trials. One study in the Canadian American Medical Journal said that that there may be more cardiac events, such as an arrhythmia. The other in the British Medical Journal says that there aren't. So Pfizer was asked by the FDA to put a black box warning, and as was bupropion for Zyban, first about the suicidal risk and about the risk of heart disease. So what do I say? I say probably, particularly with someone with a psychiatric illness, this should not be the first drug that you use. On the other hand, if someone has failed other drugs, wants to try it, or someone's just heard about it, wants to try it, and doesn't meet a contraindication, it looks like it's the most successful drug, and the consequences of smoking are so great that I wouldn't hesitate to use it. Bupropion acts on the brain probably similarly in a way to varenicline, and it decreases the cravings and it decreases the symptoms of the withdrawal. We've not pinpointed exactly where. It also is a twofer in that if you're chronically depressed, this can help you there. So its advantages are that it's easy to use, just like varenicline is. Might postpone the weight gain. The major contraindication for it is if someone has a history of seizures or if they have a condition that predisposes them to seizures, then they shouldn't take it. So it's common to use combination therapy, the patch, the long-acting NRT of the patch, plus a short-acting version, usually the gum or the lozenge, or those two plus bupropion. Varenicline has not been studied in combination, although there are now some studies that are doing that. Some people who see a lot of smokers do use it in combination. What the Mayo Clinic does, which is probably the gold standard for smoking cessation, is they use the patch, the strongest dose, sometimes 2 or 3, short-acting NRT like the gum, and bupropion. Now, these are the comparative costs of the generic and the trademark. And you might want to say, well, this costs about as much as a pack of cigarettes, which you can see. Why should we cover it? And the problem is that you can't, many people who are poor buy cigarettes a day at a time. So it costs them $5, $6, maybe $7. They can't buy a month's worth of therapy. And the therapies don't come out. You can't buy 2 pills. So this is why it's very important to try to get people on help to get it. One of the things that smoking does, but not NRT, is it activates the liver enzymes that deconjugate drugs. So what happens typically is you bring someone into a psychiatric hospital, you get them tooled up with their medicines, they're not allowed to smoke, you send them out, and suddenly when they start smoking, they're undertreated because the cigarette smoke breaks down these drugs. The other thing you should know is that since many smokers drink a lot of coffee, caffeine is broken down by the smoke, and if people stop smoking and they keep drinking as much coffee as they did, they've essentially doubled their caffeine levels, and they're feeling they say, "Doc, I've stopped smoking, I'm feeling jittery." It may be that they're getting a lot more caffeine. So when you get people to stop smoking, say either switch to half calf or go to decaf, because your caffeine levels are going to be higher. So I'm going to show you a summary of the smoking cessation literature. Smoking should be thought of as a chronic condition, and yet we don't often treat as long as they should. We treat for only 12 weeks. There's a great spectrum of how severely a smoker smokes and how hooked they are, and so if you've seen one smoker, you've not seen them all. And I'm going to show you on the next slide a summary of all the literature of all the anti-smoking trials, but I want to point out really 3 caveats. One is that people who volunteer for the studies are much more likely to be motivated to quit because they've got to come in and get their bloods tested and things like that. Second, the placebo and the drug arms both have more intensive and more skillful practice than is found in the real world. And counseling, of course, is not a single black box. It varies with the nature of the counselor. And finally, most drug trials exclude patients with mental illness. So that said, this is a summary slide. And there are 3 takeaway messages from this. One is, you'll notice in the yellow, the people who get just counseling have a much higher rate of quitting than those who try to quit on their own, which is about maybe 3%. The second thing, the second take home, is that the combination of counseling and drugs in the blue boxes gives you a much higher rate of quitting than counseling by itself. And finally, that because each of these trials differed, you can't say, for example, that the nicotine spray is better than, say, the patch. So each one works in combination better than just using it by itself. And this just shows you that a physician or other clinicians, when they just intervene and say, Joe, you ought to stop smoking, the patient is much more likely to quit, up to 2 times as much than if they don't intervene. Jody Prochaska last summer wrote an article in the New England Journal exploring the myths about smoking and mental illness. One myth is that people with mental illness have to smoke. A lot of those studies, it turns out, were sponsored by people who make cigarettes. They're not interested in quitting. Studies we've sponsored and elsewhere have shown that, in fact, they're just as interested in quitting as the general population. They're not able to quit. Quit rates are a little bit lower, but not much. Quitting worsens recovery from the mental illness. A lot of studies in the early 90s that showed that, particularly people with chronic depression, that's not been shown to be true in more recent studies. And it's been shown that if alcoholics can stop smoking, they'll have a higher rate of being sober. And that's probably true with people who use drugs too. And then they say it's a low priority problem. Well, in the short run it might be, but in the long run, the best thing you can do to save your patient's life is to get them to stop smoking. So let's talk about quit lines. What are tobacco quit lines? They provide smoking cessation counseling at no cost via a telephone number. They're staffed by trained specialists, often with a background in psychology. They give up to 4 to 6 personalized sessions. It varies by the state. And many states offer NRT at no cost or at a low cost. And the rates are just as good for using the quit lines as they are for the studies that I just showed you that combine both counseling and drugs. And yet, I'm sorry to say, most clinicians and most patients don't know about quit lines and don't use them. So it's the best kept secret. This is the blue card, which Reason Reyes is going to tell you more about, so I won't spend more on it, except to say you ought to get them in your clinics. This is a Cochrane collaborative to show that the odds ratio for just telephone counseling without drugs, the odds ratio of quitting is 1.56, and you can see on the right that those samples are huge. So to wind down, let's talk about the e-cigarette, which many of you have heard about. What it does is it aerosolizes nicotine in essentially an antifreeze like soluent. The cartridge contains nicotine. The safety is unproven, but it's probably safer than keeping smoking. They're used both as a bridge use by smokers who find that they can't smoke and would like to do something to get their dose of the nicotine, or as a starter product, and that's what worries some of us in public health, that kids will start and then move on to smoking. They probably give less nicotine and inconstant nicotine than promised. They're not approved by the FDA, and my counsel is don't use them unless the patient insists, but if they don't want to do anything else and try the e-cigarette, it's better than if they keep smoking. So how can we increase quit rates? Well, I'm going to show you on the last slide. Reframe your expectations of success. Help businesses to help their employees quit. Focus on the mental health and substance abuse population. Let people know about quit lines. If the industry gets new drugs, that would be great. Create better systems, and particularly for those of you listening, become clinical champions in the settings where you work. So tips for your office are get referral forms to the quit lines. Get a carbon monoxide breathalyzer. It costs about $500 plus a disposable mouthpiece, but it'll last for a really long time. And it's a good guide, and it's a good incentive because your patients can see that their rates drop down. The carbon monoxide part per million rates go way down. One key question to ask is, when do you have your first cigarette? And look at smoking as a chronic illness. Now, we may be approaching a tobacco tipping point. Only 12% of adults smoke in California. The national prevalence, as I said, is at an all-time low. Those who smoke, as I showed you, smoke really fewer cigarettes. The Kaiser rate in Northern California is 9%. As I mentioned, the smoking rate for doctors is only 1%. More and more smoke-free areas. The Affordable Care Act shows that health insurance premiums now can be higher for smokers. I mentioned the 62-cent packs on the federal tax. Lung cancer rates in women now, death rates are starting to fall. Smoking is more and more stigmatizing. There's going to be a mass media campaign from both the FDA and the CDC. So this is my final slide. 1/3 to 1/2 of the 45 million or so smokers are going to die from the habit. Of the 31.1 million who want to quit, about 1/3 to 1/2, that's 10 to 15 million, will die from smoking. If we went from the 3% cold turkey smoking cessation rate to only 10%, which was low in the treatment slide, we'd save 1 million extra lives. If we went up to a cessation rate of 15%, we'd save 1.5 million lives. Nothing else you could do could make such a difference. So now it's my pleasure to introduce my colleague, Reason Reyes, who will talk about how you can work in your community.
Move closer to the screen. So earlier, Barbara Murdoch mentioned that a piece of this presentation will discuss free and available resources for you to use so that you can take on smoking cessation in your practice. So my piece today is to show you the initiatives that we have done with our partners and share with you the free resources and introduce to you the Smoking Cessation Leadership Center. Why? Aside from the fact that I'm biased and I think this is the best place to work, and Dr. Schroeder directs our center, a lot of the resources that we'll be highlighting are available from our center and from our website. So the SCLC, we began in 2003. We are a national program office of the Robert Wood Johnson Foundation, and additional funding from the VA, Legacy, and various federal agencies, and we are here at UCSF. Our aim is to help more smokers try to quit and stay quit. We want to help clinicians do a better job at helping their patients quit and broaden the access to cessation tools and resources, just to remove the barrier that clinicians have told us, well, we don't know where to go for resources. We don't know where to find available tools to help us in our practices. This is a list of the clinician groups that we have worked with. You may belong in one of these categories, whether you're a nurse, a dental hygienist, a diabetes educator. Below here is a box, a black box. I will show a few black boxes in my following slides. This is the website that you can go to learn more about the particular topic on that slide. So here is a link to our partnerships. So if you are an anesthesiologist and want to know more about what we've done with anesthesiologists, you can learn more about that, and you can also contact us so that we can refer you to the work of the American Society of Anesthesiologists, and etc. One of the partnerships we'd like to highlight is the work of the American Dental Hygienists Association. Dr. Schroeder mentioned the Ask, Advise, Refer brief intervention earlier. This was actually coined by the dental hygienists back in 2003. At that time, they said that 25% of the profession were intervening with their patients who smoke. They thought a target of, by the end of 3 years, 50% of their profession would intervene. Well, when they did a survey by 2006, they found that 56% of their dental hygienists intervene with patients who smoke. And how they did it was essentially here on the right, Ask, Advise, Refer. They sent out this poster. They created this website, askadvicerefer.org. Tons of tools and presentations that the profession used to learn about and to ultimately help their patients to quit. And why community health clinics? Well, community health clinics are community-based and patient-directed organizations that serve populations with limited access to health care. They are places where smokers will likely be going to, and this is the place where we really want to also educate so that these clinics are aware of the available resources out there for smoking cessation tools. And for HRSA, 2011, a new performance measure set on tobacco, the percentage of patients 18 and older asked about tobacco use and the percentage of patients 18 and older counseled by providers to quit smoking. We recognize and acknowledge the leadership of Dr. Mary Wakefield and her leadership team in setting this performance measure, a mandated measure that will help us to realize the gap that we still need to do. And I believe that the data from these measures will be available this month. So now on to our community partnerships and what we can share with you so that you can take the information or be part of the effort should you be located in these areas. We have a partnership with the Substance Abuse and Mental Health Services Administration in the State Leadership Academies for Wellness and Smoking Cessation. SAMHSA has learned about our performance partnership technique. They came to us and said, well, can we work with selected states to bring together behavioral health, public health, and tobacco control fields? And the goal was to reduce smoking prevalence among the behavioral health population. So we went to New York, Arizona, Oklahoma, Maryland, North Carolina, Texas, Arizona, and in spring of next year, we'll be going to Mississippi. We conducted a 1 to 2 day Leadership Academy Summit, and our center has provided the technical assistance with support from SAMHSA. If you live in one of these states and want to be part of this effort or want to know more about the resources that they've gathered, we're happy to connect you with our partners from these states as well. And this link below, you can check out the action plan from each of the state academies, the detailed action plan that the state has committed to do to reduce their smoking prevalence in their state. In California, here's a state example. So building upon the Ask, Advise, Refer, we worked with the California Diabetes Educators, and they are promoting a campaign called Do You Card, CAARD. And as Dr. Shorter mentioned earlier in his presentation, type 2 diabetes is common among smokers. So this group of clinicians was a great group to work with. In 2007, we had a summit. 44% of diabetes educators refer their patients who smoked to the quit line at that time, and they wanted to increase that percentage to 75. Well, in 3 years, this cut off, but quit line referrals increased from 44% to 80% in 3 years. And this is the result of the intensive Do You Card campaign. If you go on the Cal Diabetes website today, you'll find the Do You Card campaign still prominent on the homepage. You'll find resources for Do You Card. So if you work in California, if you are a diabetes educator or know a colleague who is a diabetes educator, this is a great resource to share. We had a project with the Veterans Administration, and this is the famous Quit Now card that Dr. Schroeder has been highlighting. The VA granted the SELC with a 3-year grant, and our aim in that project was to promote the quit lines within the VA. So we promoted materials, simple materials. I hope you can see this. Like this poster. This is a blue card. It was an 800 Quit Now campaign. Other types of resources like this. And today, we have 1 million of these Quit Now cards circulated nationally. Another product of this campaign is also the publication of the VA in the Vanguard, Building on Success in Smoking Cessation. This is great reading material available on our website as well. Until today, orders of Quit Now cards we still receive from the Veterans Administration. And Dr. Shorter spoke with the VA here in San Francisco just last week. Yes. Here, the next section is on more low-cost, no-cost resources. Our center has a website. The link here is below. And we want to share this with you so that you can see this great hub of cessation resources. Again, the Quit Now card is available there for you to order. But just to stop there a bit, you don't have to order the Quit Now card from us. You can actually call and see if your state quit line will offer you free cessation resources. So let me back up. Well, maybe I won't back up anymore. But when I mentioned the work with the California diabetes educators, they partnered with the California Smokers Helpline. In California, the number here is 1-800-NO-BUTTS, and you can call 1-800-NO-BUTTS in California and get free cessation resources. You can also do the same in Texas. You call this number. It'll route you to your state quit line and find out more about where you can find and how you can get cessation resources. So back to our website, there are many quick links here, and later on we'll talk about webinars, but this is also a place where you can go to register for webinars. We have what is called a catalog of tools. So the center has been around for almost a decade now, and having worked with many clinician groups, we've gathered the cessation resources that have been helpful for them and compiled it into this nice catalog of tools document. You can download this for free from our website. Among those tools featured are these free toolkits. So on the right here, it's the Destination Tobacco Free. This is particularly helpful for those in hospitals and health systems. A great toolkit for you to use if you want to get to your hospital to go smoke-free, or if you already have a smoke-free campus and are experiencing hurdles, there are additional resources there that could help you. We also have a webinar on this topic of the Destination Tobacco Free. On your left, you'll find the Tobacco-Free Living in Psychiatric Settings Best Practices Toolkit for Promoting Wellness and Recovery. This was a partnership with the National Association of State Mental Health Program Directors, a great tool that was created by directors of NASHBIT, state directors, and they even created a position statement along with this toolkit to make the case for why psychiatric settings must go smoke-free. I'll go back to another important webinar related to that topic in a bit. Here are toolkits for behavioral health populations. Dr. Shorter mentioned that a high prevalence of smoking still exists among those with mental illness and addictions, and our partners from Colorado have developed these great toolkits. It looks like this in real form, but you can download the PDF from our website. And here is one great tool called RX for Change. If you forgot everything I've said, I hope that you at least remember the RX for Change website. This is a great resource. A lot of the information that you saw from Dr. Shorter on pharmacotherapy. RX for Change is a great tool to learn more about pharmacotherapy and the science behind smoking cessation. It was created by a group of pharmacists here at UCSF about 10 years ago. Still available and for free. You just need to log in here for free, create a username and password, and you can download everything. And we mentioned curricula because there are various versions of the tobacco cessation program. You can take the course on the 5 A's approach. You can take the course on the Ask, Advise, Refer. Dr. Jody Prochaska, that Dr. Shorter mentioned earlier, has worked with RX for Change to create a version for psychiatrists. There's a version for cancer care providers. There's a version for mental health peer counselors, and even surgical care providers. All of those are available for free from this website. There are case studies here in this website. There are modules. There's even information on drug interactions, dosages, so many great resources for you all. Here is another tool from AHRQ. It's a pocket guide. Thank you. It looks like this. The idea was that you can put it in your coat, and when you provide an intervention, it's a quick cheat sheet. It has the 1-800-QUIT-NOW number in the back, It was created for nurses, but there are now guides for clinicians, even our respiratory therapists. There is a cost to it, but a small cost, and you can get that from this website here below. And for those who prefer more anonymity, smokers who prefer the online services, there are online services here listed. Smokefree.gov is a great resource. There's a chat feature that a smoker can chat with a counselor on live. QuitNet is another resource. And BecomeAnX.org is a website, a great resource from the Legacy for Health Foundation. And it's a community-based cessation tool, social media at its best to help smokers quit. So free webinars. Our center, as we mentioned, offer free webinars on varying topics from Smoking Cessation 101, mental health and smoking cessation, youth, the topic on tobacco-free hospitals. Next week, we invite you all to, if you are interested on tobacco-free state psychiatric hospitals from policy to practice, you can register from our website. The webinar is free. In November, we will have a topic on emerging tobacco products. And if you can't make the live sessions, don't worry, we record our webinars. You can go to the same website to listen to the archives of our webinars. There's even one on e-cigarettes if you want to learn more about that. And lately, we've been able to offer CME CE credits. There's a charge of $25 per certificate, up to 1.5 credits. Nonetheless, still a great resource for those of you who seek CE credits. And networking opportunities. We have a listserv called 100 Pioneers, and this is a great place to, it's a free listserv, a place where you can correspond with other colleagues in the nation. There are about 1,000 tobacco cessation groups, tobacco partners out there who are interested in tobacco cessation and willing to share resources through this listserv. Just this week, we posted a question from the state of Arkansas who wanted a video on mental health and smoking. And we got resources from Australia, we got resources from Connecticut and from Alaska. So if you're interested, sign up, and you can also call us at SCLC via this toll-free number. And you can also sign up for our e-newsletter, all for free. So lastly, what you can do now, we can't emphasize the quit line any more than we have. We encourage you to take on smoking cessation activities if you don't already have activities in your setting. Use available tools out there. If you're still searching and unsure, please call us, contact us, join our SCLC webinars, and get C credits.